Which is the side effect that you can kill someone if you give a thiazide? Hypokalemia, is it? No. There's a side effect that is very well described, and that's the reason why you have to have a lab before and after you prescribe a thiazide. All of the things you guys say is right. You can develop any of them. Huh? Actually, severe hyponatremia. So thiazide diuretics are notorious for hyponatremia. You're going to get it on your boards. It's a combination between volume depletion and SIDH. And some patients are more susceptible than others. It doesn't mean that you shouldn't try them in the elderly, especially like a female elderly. But my advice to you, if you're going to end up like doing primary care or like looking at internal medicine patients, if you make a review of the sodium level, and if you already know that the patients have a tendency to be in the hyponatremic side, it's probably not the best therapeutic choice. It's probably best if you give them a calcium channel blocker like amlodipine. And that's why amlodipine is gaining a lot of ground, because if you're in the urgent care and you need to make a decision, you give them amlodipine. You don't have to worry about checking labs before and after. You don't have to worry about these serious metabolic effects. You just go for the safer route, and you send the message to the primary care doctor, and they can follow. In my practice, I prefer chlorothalidone over hydrochlorothiazide. Chlorothalidone is a very old drug. It's even older than hydrochlorothiazide. But what studies have shown is that it has a longer acting life. Like the thiazide start wearing off like by 18 hours, whereas the chlorothalidone is more like 24 hours. You would expect more effect and more side effects. So patients can actually have a little bit of increased risk of hyperuricemia, gout, glucose intolerance, and all the things that you guys mentioned in chlorothalidone, but it's a great medication. I prescribe it for almost everybody unless your GFR is less than 30. If your GFR is less than 30, it doesn't work. It's not nephrotoxic, but it doesn't work. It's not, you don't have any side of action. You don't have enough.
It's a loop also, right?
No, the thiazide, it works in the cortical and the distal collecting tubule.
The chlorothalidone?
Right. Okay. So they have like diuretics. The one that works in the loop are the loop diuretics like Lasix versus Bumex. And we have the carbonic anhydrase inhibitors, which is the acetazolamide that works in the proximal. And we have the thiazides that work in the cortical collecting duct. And then we have the potassium-sparing diuretics like spironolactone that work in the collecting. And then we have the aquaretics. Those are like for hyponatremia. They block the ADH receptor. Okay, so my advice is for you guys is like amlodipine, lisinopril, amlodipine, lisinopril, chlorothalidone, and still not control. You think about resistant hypertension. You rule out pseudo-resistance. And if you done your homework, like I described, you think about adding chlorothalidone. And then you think about like, does this patient need a secondary hypertension workup? That's when you start thinking about doing that. So I don't know if you heard about the Simplicity 1, 2, 3, and actually now there's a Simplicity 4 trials. So a very bright person was thinking like, okay, like peripheral autonomic system, like sympathetic autonomic system is responsible for hypertension regulation in patients, and that's the reason why sometimes patients, they have like this paroxysmal hypertension resembling like Pheochromocytoma. So they try to do a trial by actually like cutting down the what we call renal denervation. They go after the peripheral ganglia in there's a chain, I forget what it's called, in the suprarenal gland area, and they sever them, they cut them, and they try to demonstrate that this procedure was actually safe and effective. To this date, they haven't been able to demonstrate that. So they did a Simplicity 4 trial. I don't have the slides here, but again, they're still looking for ways of getting an FDA approval for this procedure, but it's not a standard of care. That's the take-home message. Okay, so this is the correct answer for you guys, and we know that referring him to the sleep clinic is going to do nothing. And ENT, yeah, you can refer him, but that's not going to fix his problem. He has like bad hypertension, and diltiazem is inferior to spironolactone. And when you start going up on diltiazem, what kind of interaction you may run into? So, so cytochrome P450, it's where DILT gets metabolized. So if you're taking high doses statins, you increase your risk of rhabdomyolysis goes up. So make sure that if you're changing the diltiazem in patients with maximum doses of statins, make sure they're not on simvastatin 80 because a lot of the cases of rhabdo have been associated with simvastatin. My advice to you guys is stay away from simvastatin. It's a cheap drug, but like a lot of the madness related to statins is usually with simvastatin 80. So if you think that you need higher, I don't have a problem with simvastatin 10, 20, or 40. Was calling me. This is not Kaiser. But if you're thinking about going up to 80, maybe switch to Lipitor or Crestor or any of the other ones. So they compete for the same site of action than the cytochrome P450. Okay, so then we have the resistant hypertension. You eliminate pseudo-resistant, you identify common non-endocrine causes of resistant hypertension, and then you excuse me. Then you go for, endocrine causes, either because the patient has specific signs or symptoms, or because somebody did adrenal imaging and they saw an incidentalloma. For your boards, you never do adrenal imaging, never, unless you have biochemical evidence of aldosterone excess. If you respond, oh, let me do an adrenal MRI, you got it wrong. And they love to ask that question, maybe because they want to teach us how to use resources in an intelligent way. So, but these are like some of the clinical associations. So primary hyperaldo which is also known as Con syndrome. So if you see on your boards metabolic alkalosis, hypokalemia, and hypertension, think about it. Or a younger person with severe end organ damage from hypertension. This is another clinical clue to think about primary hyperaldo. Pheo is very uncommon, but it's very common in the real world. My advice to you is the day before your test, grab a book and review the familial syndromes, because the bottom line is that this information is not useful for clinical practice. I always remember that there is a MEN1 and a MEN2, and there is another syndrome associated with like the neurofibromatosis type 1, and but the bottom line is it's useless information, but it's useful the night before. You're gonna forget it once you walk out of the test. You're never gonna remember that. But they may give you like a vignette of somebody with severe hypertension with anesthesia, or like a younger person, like my co-fellow, like I was just telling you, she had all these crazy symptoms, and I'm very proud of her because she self-diagnosed. And or somebody with idiopathic cardiomyopathy, like your patient, like cardiologists, they know to do a screening for Pheochromocytoma. We're going to talk about it in a minute, for every young person with unexplained cardiomyopathy, because that may be one of the clinical syndromes. And then you think about Cushing's. So like I said, muscle weakness, glucose intolerance, and the Cushingoid appearance. So, and most patients with spells don't have Pheo, but on your boards they love it. Okay? Okay, can somebody help me read?
A 37-year-old white female referred to you for resistant hypertension. Occasional headaches, fatigue, and muscle cramps. Blood pressure 170 over 100. BMI 27. Exam is otherwise unremarkable. Enalapril 20 BID. Hydrochlorothiazide. Transparent 25 over 35.5 every day. Atenolol.
I'm sorry, that's Maxide. Have you guys heard about Maxide? Maxide is a diuretic. It's a combination between a thiazide and triamterene. Triamterene is a potassium-sparing diuretic.
It's called
Maxide, M-A-X-Z-I-D-E, Maxide. So you may see some of the patients here on that medication. It's a combination.
Thank you. And atenolol 50 every day. Potassium 2.5, other labs normal. Which of the following would most likely establish the correct diagnosis? A. Fractionated plasma metanephrine.
Metanephrine.
Sorry. B, renal angiogram, C, plasma ratio of aldosterone to PRA, D, low dose dexamethasone suppression test, E, 24-hour urine aldosterone after oral sodium loading, F, TSH.
I was going with
Which?
A.
A? So what do you guys think this person has? She's
Well-
37. Oops. She's 37, right? And this is a classic triad, severe hypertension,
Con syndrome.
Con syndrome, right? And look at this potassium. So
Yeah.
the kidney, just so you guys remember this forever, the human kidney does an outstanding job holding on to potassium or excreting potassium when your kidney is healthy. So the potassium homeostasis is an excellent, tightly regulated mechanism. If you have someone with hypokalemia, that needs to be investigated. There's got to be some degree of mineralocorticoid excess, or the patient is one of those psychiatric patients that are using diuretics and they're not telling you. There's got to be something going on, but the human normal kidney does an outstanding job controlling potassium homeostasis. So this is the biggest hint. So when you see this, think about Con syndrome until proven otherwise. So we all agree this person probably has Con syndrome, right? So the next thing you need to do on your boards is to concentrate on what is it that they're asking me. When I was developing my skills to take my boards, I always go to the question and I read then the head of the question, and then I read the question again. So I read the question twice because they always want to trick you. Sometimes it's like, what is the most likely to establish the diagnosis? They're not asking you what is the screening test. They're not asking you what is the diagnosis. Sometimes they ask you what is the most important next step in the management. So if you don't understand what they're asking you, I got so many questions wrong when I was practicing, and then I developed that skill that I want to pass it on to you guys. Read the question twice, and that way you realize man, I knew this question, I just messed it up because I didn't read it correctly. So this person has Con syndrome, and what's really going to establish the diagnosis is a 24-hour urine aldosterone after oral sodium loading. I'm gonna show you a little bit of the workflow. I don't want to spend a lot of time on this because it's out of your scope of practice, but at least I want to just go briefly so you guys know what we do for these patients. Okay, so primary hyperaldo is the most common endocrine cause of secondary hypertension. You can tell that in the general population is about 5% prevalence, but in the resistant hypertension it can be as high as 23%. So that's why I'm telling you guys, if you're dealing with resistant, then that's an indication to do secondary hypertension workup. And but the reality is that a lot of these patients, they go unrecognized, and nobody diagnosed them, and they probably spend their lives taking 5-6 medications for blood pressure, or somebody was reading the paper about the ASCOT trial and then realized this person probably needs spironolactone. I'm going to give a spironolactone, and that took care of a blood pressure problem, and nobody really cared to investigate, because we all know that the treatment for primary hyperaldo is spironolactone. Some patients are candidates for surgical resection. I'm going to show you the workflow so you get an idea, but it is irrelevant for your practice. Okay, so the way I think about it is this person is possible PA, so the screening test is the aldosterone over plasma renin activity. Okay? The way I always had a hard time, what is the numerator, what is the denominator? So if you guys remember R, that's how I remember R. The A is the aldosterone, the denominator is the R. So that's how you're able to tell, and if it's positive, that doesn't confirm the diagnosis, that makes you a suspect. And then you do a confirmatory test, which is, they have different tests, but the one that is more sensitive, more specific is the 24-hour urine aldosterone after an oral sodium loading. Okay, there's a lot of problems with the aldosterone and renin because the timing they recommend is a mid-morning draw. If your diet is sodium restricted, you may not have a lot of aldosterone circulating, so they recommend that you liberalize sodium, but the reality is who does that? Who tells the patient go ahead and eat McDonald's every day for 3 days? Position, patient supposedly when you're sitting, your level is different than when you're laying the cubitus. And the specimen handling. So in the real world, it's not convenient. So I use every test that I send, I use it with a grain of salt. I think about like, okay, if I really have a high suspicion for primary hyperaldo, I just go straight to the 24-hour urine aldosterone. I'm going to show you. And the problem with this test is also that there's different definition of what's normal and what's abnormal depending on the textbook that you review. But one thing that we all universally agree upon is that the higher the number of aldosterone and the higher the number of the aldosterone over plasma renin activity, the more likely that you're dealing with the real deal. But the reality is that in the United States for many decades, the American Society of Endocrinology, they have been issuing the recommendations for hypertension and secondary hypertension. And if you review that guideline, the last time they published it was like 8 years ago. And they're telling clinicians to stop everything that the patients are taking and to switch them to medications that don't have an effect on either the renin or the aldosterone. And I don't know what kind of world they live in, because if I have a patient with severe hypertension, I'm not going to stop 5 medications, I'm going to give them another 5. It's not practical. It's just not safe, the way I see it. And I'm again, don't quote me on this because this is the American Endocrine Association recommendation. But in clinical practice, it's very cumbersome. I'm never going to stop 5 medications to give you another 5 medications that you may have side effects, and more importantly, you may develop like severe hypertension from the switch. But this is just a tool that Ramiro is going to send you a PowerPoint so you can do for review if you're interested in this topic. So a beta blocker is a direct renin inhibitor. So if your renin is very low, if your denominator is low, you're going to get a false positive. So by the same token, if you're actually using an ACE and an ARB, it lowers your aldo and increases your PRA, so you're going to get a false negative. So all of these medicines have a problem. But it is what it is. It's the best you can do. So what I do is when I suspect it, the best scenario is that the patient comes in. I'm going to rule it out. I haven't started you on any medications. You go really quick to the lab, give me a blood sample, and come back for your prescriptions. That's normally how I do it. But when someone is coming in already on 5, 6 medications, and if I have a high clinical suspicion, I just go straight to the 24-hour urine for aldosterone. This is what I was just telling you about the recommendation from the American Society of Endocrinology. Okay, so these are irrelevant for you guys, the denominator problems, the examples. All right, like I said, I go to a confirmatory test. So a confirmatory test, these are the 4 different options. The saline infusion requires that you admit a patient. It's very inconvenient. An outpatient salt-suppression, I've never done it. I don't even know how to do it. Fluorocortisone stimulation, you prescribe fluorocortisone to your patients. Fluorocortisone can cause severe hypertension, so because it has a lot of mineralocorticoid activity, so I don't do that. In a captor pill challenge, it's part of history. I remember seeing that when I was in medical school. I don't think no one does that. No interventional radiology. So what I do is usually an outpatient salt suppression. You do like a 3-day of high sodium diet. You can either prescribe sodium bicarbonate tablets, or you can just tell the patient, you know what, you're gonna have like 2 of these. What's the name of those soups that you put hot water and?
Oh, cup of noodles.
Yeah, cup noodles.
Ramen. Yeah.
Ramen.
Yeah, either one. Yeah, they both have like 4 days.
I know that they saved my life many times when I was in training. So, yeah. So you tell the patient you have 2 of those a day for 3 days. That's going to be good enough sodium. I mean, excessive sodium, I would say, excessive sodium intake. And the reason being is that if I'm trying to prove that this person has inappropriate aldosterone secretion, remember from physiology that excess sodium is a suppression factor for aldosterone. So if a lot of sodium failed to suppress aldosterone, you're dealing with the real deal. And that's why we tell the patients you're going to have a lot of sodium, you're going to collect the urine on day 3 for 24 hours, and if the urine aldosterone is greater than 12, you have the diagnosis. And the higher, the more serious the problem. So when you have a confirmatory test, when you have a confirmatory test, then you I don't know who's calling. when you have a confirmatory test, this is how you do it. Basically, the same thing. Like some doctors prescribe like these packets, sodium packets, but I just go eat McDonald's. Chips, yeah. Yeah. So if you, okay, go ahead and somebody help me read the question.
You intensify her blood pressure meds and give potassium chloride supplements. She does the salt suppression test. The potassium is 3.6. 24-hour urine comes back as 1.2 grams creatinine, 280 millimoles of sodium, and 54 micrograms of aldosterone. You've just diagnosed PA. What are you going to do now? Celebrate.
So, what do you want to do for her?
I've heard stuff about the adrenal vein sampling, like in order to...
Right.
I don't know if that's like the gold standard for it.
Right, so if you have a young person and a surgical candidate, this is how I do it. If you have a patient with a lot of more comorbidities, I don't even look for these things, because the reality is, like, no matter what you find, you're not going to be able to refer them for any surgical management. But the textbook, the correct answer from a textbook perspective is that if you demonstrate that you have a lot of aldosterone, you need to move on to the adrenal imaging. And the adrenal imaging can either be done with a CT with IV contrast, which I never do because a lot of my patients have CKD, or you just do an MRI of the adrenal glands, and you're able to look for either an adenoma or hyperplasia. They both can be associated with primary hyperaldo. But it doesn't stop there, because even if you have an adenoma, you need to demonstrate that the excess of aldosterone is coming from that specific adrenal gland. Because the last thing you want to do is to subject the patients to adrenalectomy. And at the end of the day, that wasn't the gland that was actually secreting the excess of hyperaldosteronism. So that's the reason why after you take the imaging and you demonstrate that there is hyperplasia or adenoma, you need to refer them for adrenal vein sampling. It's basically, it's done by interventional radiology. They cannulate both adrenal veins, and they simultaneously withdraw samples, and they measure the amount of aldosterone that's coming from this and from this one. And then if you have like the biochemical excess, then you have an adenoma, and then you demonstrate that the excess is coming from that gland, bingo. You can tell the patient, hey, you know what? There's a good chance that your hypertension may be cured with excision of your adrenal gland. You have to, I have a colleague actually that didn't tell this to the patient was very upset. You have to disclose to the patients that this is not a guaranteed job. And it only works about 60% of the times or 70% of the time. So if you have a young person, like let's say I diagnose you guys with PA, you're so young, I'm going to encourage you to pursue surgery, because the deleterious effect of aldosterone throughout your life, it's going to be pretty bad. We have aldosterone receptors everywhere, in the endothelium, in the GI lining. You can develop severe disease from being exposed to a lot of aldosterone. So like a young surgical good candidate, I always encourage them to do it, but I always tell them, be aware that you may have primary hypertension with superimposed PA, and this is not going to be curative. But if it's not curative, I guarantee you that the need for medicine is going to go down. In other words, if you were previously on 4 medicines, you may just get away with 1 medicine to treat your hypertension.
What's the cause of the only 60 to 70%?
Like I was describing, some patients may have...
But they have underlying primary...
Right, or like the aldosterone may be coming from both glands, and you cannot do a bilateral adrenalectomy, because you're going to effectively kill the person when they wake up from anesthesia. They're not going to be there. Everything. You're going to be like pretty much gone. So we never refer the patients for adrenal insufficiency. And so you order your adrenal CT scan, and then you found out you have an adenoma. The next thing that you do is you refer for adrenal vein sampling, and this is just to show you that a study that they did with 54 patients with PA. They realized that like a lot of the times, like the patients really have like equivalent average blood pressure, like compared to medical management. So this is when you start thinking like, do I want to refer these patients? And again, I'm going to tell you one more time, if it's a young person healthy otherwise, I refer them, you know. But you always have to tell them that spironolactone is probably the only thing they need. The problem is that if you give spironolactone, most patients, most male patients, they end up having a problem with nipple sensitivity and gynecomastia. And female patients, they complain a lot of nipple sensitivity on this medication. But the way I sell it to my patients is like, you know, it's either this one drug versus 4 drugs and having the risk of developing end organ damage from hypertension. So that's a good selling point. And you need to educate the patient that, you know, spironolactone is a safe medication and is the treatment of choice for this entity. So you refer, like, you know, like I said, sometimes patients that they've done case series and they realize that 20% of the patients had an inappropriate adrenalectomy. And that's pretty lame. Imagine if your patient gets the wrong adrenal gland removed. I mean, you're going to be so pissed off. So you need to confirm that the excess is coming from that specific gland with adrenal vein sampling. And then the patient underwent laparoscopic left adrenalectomy, and now blood pressure is controlled with monotherapy with lisinopril. That's usually the most common outcome. Okay, so one more time. You think about possible PA, about the things that I talked to you guys. Younger person, hypokalemia, metabolic alkalosis. You do the screening test, which is the R, aldosterone over plasma renin activity. The higher, the more likely. Greater than 20 aldosterone, greater than 20 for the ratio. And if you suspect it, you do the confirmatory test. And the confirmatory test is the 24-hour aldosterone. And then if you have it, you go for imaging. If you go for imaging in any level here, you're going to get it wrong. And the boards, they love to ask that question because everybody gets excited, like, oh, this person has an incident, biochemical excess. You have to demonstrate it before you jump and do the adrenal imaging. So another reason to do imaging, it's because the bigger the mass in the adrenal gland, the more likely that you're dealing with a malignant mass. Like anything greater than 3, you start getting like, maybe this person has an adrenal malignancy. If the mass is like 7 or 8 centimeters, you better believe that probably you have a malignancy. It's a slow-growing malignancy, but that's another reason why we do the imaging, because you need to follow it over time. And which specialty follows these adrenal masses? Which specialty are you going to refer, like, from follow-up of these masses? Which? Who?
Would it be a urologist?
Urology. Urology is the one that follows this, you know. Same as like abnormal renal masses. Okay? So surgery not desired or not a candidate, you treat medically with medication. Which medications? Spironolactone, right. So surgery is desired, you need to do the AVS. If you're pretty certain that it's coming from one, you refer for surgery. If you cannot demonstrate that the excess is coming from one, you need to just go back to medical treatment.
So if it was bilateral disease, there would be no benefit from like removing one of the glands?
No, it's not recommended. Because the chances is like it's not really going to change anything. So if you see like the excretion is equal, you have to tell the patient, you know, you only have one choice, which is medical therapy.
Is there a certain cutoff where it is bilateral, but one is much more severe than the other?
Yeah, that's when you use your judgment and you talk to the patient, you know, like this one is 50% more, we can go for this one. But you have to be very honest with the patients, because imagine like going through all of this, surgical risk and everything, and you didn't accomplish anything. Yeah. Okay, somebody help me with this one?
I'm going to refer to a 71-year-old woman for resistant hypertension. She has spells, basically headaches, palpitation, anxiety, tremors, chronic pain, acetaminophen, and amitriptyline, otherwise asymptomatic. Blood pressure 180 over 65, plus 78, normal weight, and left low exam. For sartan, amlodipine, and atenolol. Recently performed a CT abdomen with contrast, which was normal, and fractionated plasma membrane. Asthma and non-epinephrine 1.2 picomole per liter, and plasma metanephrine is 42 picomole per liter, which that was normal, but the above was high. Which of the following statements are true?
So it's basically the typical description of symptoms, pretty severe hypertension, and then they basically did plasma metanephrines, which is mildly elevated. This is a normal reference range, and this is like 1.2, and the plasma metanephrine is normal. So basically, the question is, does she have Pheo? We're gonna learn how to distinguish it. It's common for patients with Pheo with spells to have normal appearing adrenal glands. It is common for patients with Pheo with symptomatic spells to have mildly elevation of the fractionated, or the elevated plasma norepinephrine was probably a false positive. So this is the correct answer, because the textbook definition is 3 times the normal value, or some textbooks actually recommend that it should be 5 times the normal value. And you're going to learn this because a lot of the over-the-counter stuff that we use can actually give you a falsely elevated level of metanephrine. So I'm going to cover that in a minute. So again, 90% are in the adrenal glands, but you can have an extra adrenal pheochromocytoma. And in the appearance in the CT, I wouldn't say it's pathognomonic, but if your radiologist is calling it a Pheo, you better believe it, because the appearance of that mass is very characteristic to them, because they're familiar reviewing these films. It's like a irregular, large, cystic mass, and I always take that very seriously, because this disease has a pre-biochemical phase. In other words, you have the mass, you measure, and there's nothing there, but this patient need to be under like very constant surveillance, because they can become biochemically active at any given point. So these are all medications that can give you a mildly elevated metanephrines in the blood. So a lot of them can be like over the counter, like Sudafed, alcohol, but some of them are also like decongestants, TCAs, tricyclic antidepressants, or even clonidine. Withdrawing from clonidine can give you an elevated metanephrine level. So again, usually 5 times, not just a little bit, 5 times for you to be able to call it. Okay. All right, this is the answer, okay? Okay, help me with one.
You're confronted by a seemingly well 45-year-old woman who's presenting for the first time after avoiding medical care for the last 10 years. Her blood pressure in your office measured once is 151/96. Both of her parents had high blood pressure. You should A, gather more blood pressure data where they're measuring it again on subsequent visits, or B, initiate antihypertensive therapy with one or more drugs.
Easy one, right? Okay. Lightning round 2.
You set her up with an ambulatory blood pressure monitor. Her average 24-hour blood pressure is 147/91. Her serum chemistries, urinalysis, and serum creatinine are all normal. You should review potentially modifiable lifestyle methods of lowering her blood pressure, including weight loss if overweight, moderation of alcohol intake if excessive, exercise if inactive, and dietary modifications with a goal blood pressure of less than 140/90. Review potentially modifiable lifestyle methods of lowering her blood pressure, including weight loss, moderation of alcohol intake, exercise, and dietary modifications with a goal of blood pressure up less than 130/80. Initiate antihypertensive therapy with one or more drugs with a goal blood pressure of less than 140/90. Initiate antihypertensive therapy with one or more drugs with a goal blood pressure of less than 130/80.
Did she have any kidney?
She didn't have any kidney.
She didn't have any what?
Kidney disease?
No.
The first part?
It's just a healthy person, yeah. Should be A, right? So the JNC8 is less than 140/90. This goal of less than 130/80 is individualized to some patients with end organ damage, like some of my diabetic renal disease patients. I target like 120s, but generally speaking, you still have a person with mildly elevated blood pressure, like stage 1 hypertension, and you can possibly, revert that by doing all the right things, right? Okay, lighting in round 3.
After eating a healthier diet, exercising more, and losing 10 pounds, she achieves her goal blood pressure. However, at her routine visit with you 2 years later, her blood pressure is again high at 150/95. Over the prior 2 months, she has had similar home blood pressure readings, which she takes twice per week. She has maintained her healthy lifestyle. You should. A, start atenolol. B, start HCTZ. C, start chlorthalidone. D, start minoxidil. That's an old drug.
Yeah, it's a dinosaur drug.
Would it be B for, I know you were talking about that you prefer.
I prefer chlorthalidone. That's why I put it so you guys remember. Chlorthalidone is my drug of choice, but remember, you have to have labs before and after, right? Hyponatremia can be fatal if you don't check labs before and after, okay?
But for, like a
Board's purposes.
JOTA or boards, it would be HCTZ? Or
Either way, I don't think they're gonna, the boards are very clean. The boards are never do this controversy because this is more like a style, like a preference.
Does anyone use minoxidil anymore?
If when I see
Other than
patients,
for Rogaine?
you know, like I need that. So, are you kidding me? Yeah. So I do a lot of hypertension consults because I'm a hypertension specialist. Like that's like a board certification. So I get patients coming into my clinic with a bunch of medications, and what I always teach the students is that patients that come in with these medicines, I already know that they either have an extensive history of allergy intolerance, that when I review them, they're not really not an allergy nor an intolerance. And it's important that you guys know this because in hypertension medicine, there's so many medications that you can use. And when you start exhausting the first lines, then you're moving on to these dinosaur drugs. When I was in medical school, I saw a patient die from a pericardial effusion that turned into a cardiac tamponade from minoxidil.
Whoa.
That stuff has serious side effects, including like renal sodium retention. Believe it or not, it's a vasodilator, but it can actually increase the renal sodium excretion, and the patients develop like a lot of edema when they take that stuff. So in advanced kidney disease, it's a bad choice, and some doctors they use it, but when I see it, either I think about like a truly resistant case with multiple allergies. My job is to review whether or not they're true allergies and just to offer the patient with the evidence, because if you come to me and I'll tell you a thiazide diuretics is much better than minoxidil, and I show you the evidence and the studies, you know, the evidence is pretty good for thiazides. Why would you want to be on minoxidil? That stuff is really, it shouldn't be used as first line. Or the patients basically, they really have no other choice. Like what happened with that patient, by the way, the ones that you had like with severe hypertension?
I actually saw her. She ended up going to she was supposed to go to the hospital, but then she said that she didn't want to when I called to follow up with her. So they said that they were going to see a nephrologist.
Yeah.
And then I don't think they ever did that, but then I think she went to the hospital. And so I think she went to the hospital.
She needs dialysis. That person, like, remember we talk about like the...
But she was very adamant because I kind of, what you were saying last time, asking about the salt. You know, and well, do you add salt to your food? Do you like
Eat out.
eat out a lot? And it was very, she didn't really want to talk
Very
about
vague.
it.
Yeah.
Yeah.
I'm telling you, in this business, they're all horses. I've seen a Gordon syndrome once. I saw a Little syndrome once. Like an apparent mineralocorticoid excess once. And like a bunch of other syndromes that I've never seen in textbooks. In my boards, my hypertension boards, they ask me those questions. But the reality is that if you're an excellent clinician, you can deal with almost like 100% of your hypertension patients. The problem is that we do the easy route, which is prescribing. It's a lot easier to prescribe than sitting down with them and reviewing their habits and educating them about weight reduction activity, sodium intake, medication compliance.
When she was in the office,
That's hard work.
her O2 stat was like 76.
Yeah, she needs
She has
dialysis.
COPD?
I think she had COPD, yeah, as well, but
She was pretty volume overloaded.
We tried to explain, you know, that less than 94 is, and you're at 76, so there's quite a significant difference. And she just, Dr. Ben-Zur talked to her.
And she had like effusions, you told me, right? She also had like pleural effusions, or?
I believe so, yeah. I only saw her once. Erica was mainly seeing her.
That person has like severe hypertension and like probably needs dialysis. That's the only way you're gonna fix her. Yeah, so my job is to go over these simple concepts, but it's hard work because it's the hardest thing. Like changing behaviors is the hardest thing to have your patients accomplish. And going back to medications that somebody wrote them off, you need to give the patients a lot of education and a lot of confidence that it's going to be okay. If you have edema with a calcium channel blocker, that's not an allergy. You're almost always expected to have some degree of edema. So your job as the doctor is to reassure your patients that if it doesn't bother you, it doesn't bother me. And you can teach them little tips on how to improve that. Like you may tell them, you know what, why don't you just elevate your legs, or why don't you wear compression stockings, or why don't we try to eat less salt or drink less fluid. How much fluid should a renal patient drink? Like 1 or 2 liters, right? But the reality is that we all hear that drinking a lot of fluid is good, is beneficial. And there's a lot of like BS out there, sorry for my vocabulary, but with the alkaline water and trying to sell patients like a lot of like this nonsense. And then people believe that drinking a lot of fluid. So once they tell them, you know what, you have kidney disease. Oh, I have kidney disease, I need to drink more. Guess what? You have a clogged sink. You're going to overflow if you keep putting water. So you need to teach those principles. You need to refer the patients for formal low sodium education. I'm blessed because I have a dietitian and she's very qualified. And you'll be surprised if you go to one of those classes, you realize like, man, I really know nothing about like eating low sodium, because we don't need to do that until we have to. Yeah. So that's my job, to teach them that, yeah, that's not an allergy. Maybe it's a tolerable side effect. Or sometimes the patients, they end up developing, let's say, like angioedema on an ACE inhibitor, and they don't try an ARB because they're afraid that they may have the same outcome. It's safe to use an ARB if you had angioedema. Another very common one is that the patients come in with, let's say they start getting gout with a thiazide and they stop it, and then you're going like to more advanced medications. You tell the patient, you have kidney disease. Even if you stop the hydrochlorothiazide, you're probably going to have gout again. So if you're confronted with a medication question, I just tell them, let's use a little bit of allopurinol and bring it down the uric acid. You're never going to have a gout attack. So there's so many different things that you need to illustrate your patients about compliance, about sodium, about teaching them about side effects. My job for you guys is like, if you're not going to use an ACE inhibitor, you have to have a very compelling reason, like a life-threatening side effect. Because an ACE inhibitor, if you negate an ACE inhibitor to a cardiac or a renal patient, you're doing a disservice to that patient. Some of the doctors, they feel like, oh my gosh, the potassium is 5.6, I'm going to get rid of this ACE inhibitor. Don't do it. Just educate the patient or refer them for formal potassium education. We know that you're saving lives, remodeling and slowing down progression of kidney disease. So that's why.
Sorry.
No problem. Yeah, go ahead.
So with the edema, when the patient complains about it, would then you want to change it up if they're complaining?
Yeah. If it's severe, it's dose dependent, but you can teach them to do the things that I just mentioned, the strategies that I just mentioned.
Yeah. I don't know. I was just asking because
right.
my dad was put on amphetamine, and
it's very common.
He's paraplegic though, and he could no longer fit into his shoes, and he was wearing the compression stockings and elevating his legs at night. But because he couldn't wear his shoes when he's like wheeling around, he can't feel his feet, so he could get like bruises and then.
So it's like a safety issue for him.
Yeah. So would that be something?
Why is he paraplegic? I'm sorry to ask you.
Oh, he broke his back when he was younger.
Okay.
So.
Right. So.
Would that be a case to change?
Does he drink a lot of fluid?
No.
He doesn't drink a lot of fluid. Has he measured how much fluid he drinks? The edema is coming from somewhere. So yeah. So I don't know what his diet is in sodium. So you may want to try to just tell him to drink a little bit less. But there are many other options. He doesn't have kidney disease, right? Yeah, they can use many other options. Like he should be on a thiazide diuretic, for instance.
Okay, so
yeah.
It's rare that because he was started on it like 5 years before I even went to PA school, and the drug they started him on was nifedipine.
Like as a first line?
Yeah.
I never used nifedipine as a first line. Nifedipine is a very powerful medication, and I use it for kidney disease. In other words, when you're already losing your GFR, I replace amlodipine with nifedipine. which is longer acting and is more powerful. Like I was just telling you the other day, I don't know what would I do if I didn't have nifedipine for my kidney disease patients. But for your dad, if he's just as a monotherapy for hypertension, they could have used something else. They could have used a thiazide diuretic, for instance. But make sure that they check his labs before and after.
Yeah.
And if he's being hyponatremic, I don't recommend that they do a thiazide. Yeah.
Thank you.
No problem. So then we have your patient who has end-stage kidney disease. She's not on dialysis, but it's very clear, like all the symptoms that you told me, her numbers are very consistent with end-stage kidney disease. So how do you lower the blood pressure in these patients? So in dialysis patients, we always look at the weight. Always look at the weight. So if you interview a dialysis patient here, I want you to ask them several questions. I want you to ask them, what is your dry weight? So we educate the patients that they have a dry weight and they have a water weight. So the water weight is the weight that they gain in between the dialysis treatment. And that can vary from a few pounds to a lot, many kilograms if you're non-compliant. And as you're being a dialysis patient for some time, most patients, they stop peeing. And they become very dependent on the dialysis machine. And they stop peeing because it's just the nature of the kidney disease. They progress. And especially when we start using a lot of the ultrafiltration features from the dialysis machine, we're causing more and more damage to the residual kidney function. And most patients, if you ask dialysis patients, ask them, do you still pee? If they pee, it's a blessing. You try to preserve that residual kidney function. You don't give them NSAIDs. You don't give them contrast unless you have to. So that's one thing. The second thing is that you ask how many kilograms they take out. So if he tells you, oh, they took 4 or sometimes more, you already know that you're dealing with a non-compliant patients, because the recommendation is not to gain more than 1 kilogram per day. So dialysis patients get dialyzed 3 times a week. There's 2 different shifts, Monday, Wednesday, Friday, Tuesday, Thursday, Saturdays. So today, I always get the patients getting admitted with a lot of volume because it's the long weekend, from Friday until now, or from Saturday until Tuesday. Patients, they tend to get admitted more from volume overload. But this is the way dialysis has been done like this for decades.